Thank you for providing me this opportunity. GOA President and Secretary and the Plus Orthopaedics company for sponsoring our session. We'll keep cases and I will keep running through and ask experts for their panel opinion. This is a 40-year-old gentleman who comes with primary right hip pain. He is a childhood case of Coxa-Vara. So the textbook learning is teaching is that you don't intervene in Coxa-Vara until they are symptomatic. So first, Giridhar, what will be your plan of treatment in this patient? I think we are going ahead with total hip replacement. I need your inputs.
I think you can try with a normal implant.
Okay.
Canal is okay. Like maybe you can go with regular stem, uncemented regular stem.
Okay.
But you have to see there is right side there is more of ankylosis.
Yeah.
So
that is one good point mentioned.
Yes.
There is some ankylosis.
Ankylosis is there. So you need to see how is your acetabulum. So depending on that, maybe you can have a standby trabecular cup.
Okay.
Trabecular cup, and then you can go ahead with the regular one, I feel so.
Okay. Yeah, but the only downside of a regular implant is you will not be able to replicate the native biomechanics of the hip, because the regular implants usually come with a 132-degree offset. There are really no uncemented implants.
Problem. The offset would be a problem with the regular.
So I think we should be able to sink the implant more.
Then you have to go with Wagner stem. Then once again Wagner stem you have.
Yeah. And a modular, I think it will be a better option.
Modular is okay. Modular you can plan.
You can plan. Sir, Amar sir, your opinion on this?
And before we choose the implant, primary thing is we have to look at the soft tissues.
Yeah.
Because the whole greater trochanter looks very close to the roof of the acetabulum.
Yes, sir.
So whether if soft tissues are not lax enough, you won't have room to maneuver there. So first thing, probably my concern would look at soft tissues.
Okay, looking at soft tissues, so you mean to say any need of adductor tenotomy?
Yeah, adductors or even the abductors will be shortened very much. So,
okay.
I mean, since you operated, how did you find the exposure with the normal?
I think the exposure, I faced some difficulty in dislocating the hip, but it was ankylosed. It was almost a fibrous ankylosis. So in situ, I had made that neck cut and got away with it. But otherwise, in this case, as you said, I was not trying too many heroic measures. So compared to the left hip, because he's completely asymptomatic on the left side. So my primary goal was to replicate the left hip. So if we want to lengthen this hip, it would be a problem. But if you want to just put a hip implant inside with the native biomechanics, so I don't think we need to lengthen this hip, because he's completely asymptomatic on left side. If you lengthen this hip, that would be a problem.
So probably you would aim for a little high hip center and fix the cup little higher up.
Okay.
If the bone stock seems to be adequate, young fellow and all that.
Okay.
You can go for a little higher hip center so that your normal implant will fit into it.
Fit into it. Yeah, that is also one option, sir. Because long-term studies are mentioning that even high hip centers also, they give good results. It's not that your X-ray needs to be very perfect with a equator like thing to the left side. But on the contrary, we went ahead with a hybrid implant. The choice, why did we go with a hybrid implant, means the cemented implant on the femoral side would allow us to sink in the stem as much as we want, so that we can replicate the native biomechanics of the left side without lengthening this hip. Because if we lengthen this hip with some uncemented implant, he would create a problem that my hip is lengthened by, right limb is lengthened by 2 or 3 centimeters and he will face difficulty. So preoperatively also I asked the patient, will you be able to accept the lengthening? So he told that I am very perfect with the left hip and I don't want left total hip replacement in the near future also. So with that consent, I accepted a hybrid total hip replacement for this guy. I think he's now fine.
But you got some lengthening, right?
Sir, clinically బాగానే ఉంది సార్.
Okay, when X-ray looks a little lengthened.
Yeah. Might be. That is acceptable. I think 1 centimeter plus or minus is acceptable. We maintained, but this would not be possible with a traditional uncemented implant. That is, I think, the learning point over here I want to mention. This is another case, 30-year-old female with right side ankylosed hip, and she has been suffering from this since the last 15 to 20 years. Some childhood septic arthritis or tubercular arthritis. Actually, I investigated her, and it was a flexible scoliosis. Okay, so didn't refer to a spine surgeon. And anyway, I have a spine surgeon with me. Flexion deformity, yeah. She has some flexion deformity. Flexion and slight abduction deformity as well, sir. Adduction deformity, sir.
Teaching that if you have flexion deformity, you try to go with a lateral or anterolateral approach. So,
Yeah, yes, sir. But I'm not so well versed with anterior.
I'm just asking.
Yeah.
We read all the time that if you have a flexion deformity, you should expose either anterolateral or anterior approach.
Yeah,
So,
yeah.
how did you circumvent the problem? What is our familiarity with that approach and custom? Always posterior approach when we are doing, I think, anterolateral also to be okay for the surgeon. So.
No, I am not familiar with the Harding anterolateral approach. I would have preferred an anterior approach for this case, but still I am decently confident with the posterior approach, so I went ahead with it. There might be a little controversial thing because traditional teaching is if an ankylosed hip, I think as sir mentioned, it is always better to go from anterior or anterolateral, but we had gone ahead with the posterior approach, sir.
Regarding scoliosis was flexible scoliosis, right?
Yeah.
So were you able to get the both ASAs at this? Were you able to approximate both ASAs at the discrepancy?
No, I didn't find any limb length discrepancy because you can see the both lesser trochanters at the same level if you parallel the pelvis.
That's what. Pelvis is parallel with the flexible. Scoliosis was flexible.
That is why the scoliosis was flexible. She doesn't have
there is
any.
No limb length discrepancy at all.
No, she doesn't have any limb length discrepancy. Maybe after post-op I might have created limb length discrepancy. But so, what is your choice of implant? Anything special or? Okay, whatever the approach may be.
I would like to go with the regular uncemented. Age of the patient 30 years.
30 years.
Uncemented, regular uncemented. But how is the from here I can see that the X-ray acetabulum is quite okay. So acetabulum is quite okay. So you can go with the regular uncemented TH.
Okay. So Mridula, I think do you want to use CM in your surgery for this case to locate the acetabulum, or are you decently confident that you will be able to locate the acetabulum?
It's always better to use a CM if you are not sure of your acetabulum.
Okay.
Yeah, you need a CM, but anyway, you are almost creating your own acetabulum here.
Okay.
So, I mean, there is good, strong bone stock with the trabeculae.
Yeah.
And if you ream properly, I think you should get a fairly deep, good sized cup inside.
Yeah. Because the difficulty I faced, I want to tell you that because I am only familiar with the posterior approach, I had gone with the posterior approach. So, as predicted that you will be using a neck cut, and after that, for location of the teardrop and the true acetabulum, I had to use the CM. But only thing with the posterior approach and the lateral positioning, CM usage will be a bit difficult, but still manage to get this hip. The anterior approach, if we are using, I think CM usage would be much more easier. So we went ahead with a traditional uncemented total hip, and as everyone predicted, there is, I think, slight lengthening of around 5 mm or 1 centimeter. Still looks short in Lakshmar, and then I think I should refer to you for Ilijaro. అదే అందుకనే అయ్యా pelvis is not squared. But 1 centimeter plus or minus, I think we can accept, Lakshmi. Yeah, actually, the patient was telling that the limb is lengthened because I think, and another thing is she is a female. So her native biomechanics, the offset should be around I think 125 to 127, not more than that. But only with a traditional uncemented, you can go up to 132. So her offset is more. If you can if you compare the right and left side, lengthening is okay, but her offset is more. The horizontal offset is more. So they will always have a feeling of lengthening because that is false lengthening. This is what we learn, no? We traditionally abductors will become tight, so abductor her ASAs will be a bit low, so that might be a false lengthening. So this is another case I have done. This is one of my first cases during my private practice, done some 10 years back, a hybrid total hip. This guy has fell down in a bathroom, so came up with this picture. So how to deal with this situation now?
You can once again remove the cement and remove the implant and go ahead with like
Cup is fine, sir. Cup is fine.
even you can go with ATO, extended trochanteric osteotomy, remove the complete implant and the cement.
Okay.
Go with uncemented long stem,
Uncemented long
revision stem. What I feel, revision stem and uncemented cup.
Uncemented cup. Uh, sir, actually, cup looks pretty good.
So there is
But
some
the change, if we want to change the cup or not, it depends on the revision situation on the femoral side, sir. Because if you want to put a 36 head, it might not be possible. Yeah, that is what I'm just mentioning. If you want really 36 head, then I think also you can just change the liner. Liner. Still. Cup looks, yeah, you don't, there is no fun in taking part. Femur.
You have to put augments and all that. Your cost of the implant is going to pile up.
Yeah.
do you want to do it?
No,
Because
no. As you know, I am a very conservative surgeon, sir.
Excessively conservative.
No. I did something a bit more different. I chose cement in cement revision. Luckily, I had put a second size cemented stem in the previous case, in the previous surgery. So I was able to get away with a cement and cement revision.
Lesser size.
Yeah, lesser size and more cement mantle. Sir?
was
No.
the stem loosened
No,
or was
no,
it?
stem was not loose. Stem was not loose.
So you mean to say
If is there any loosening at the cement mantle and
Yeah,
metal
what-
interface?
There is a loosening.
Yes, sir.
This break in the neck would have been a fatigue fracture
Okay.
because of cyclical loading. So this
Fall
because broke, or did he implant break because of the fall?
Yeah, it's a very difficult question, sir. But intraoperatively, I saw the implant was not loose.
Stem is not loose, then
Yeah,
the fall might have broken the implant.
yeah, the fall might have. When the stem is loose, it usually causes that periprosthetic fracture. Or when the integration is not perfect. These are high energy trauma. Anything can happen. In that way also it can happen. Because periprosthetic fractures we usually see in osteoporotic patients where we have uncemented stems. There was an Australian registry data also that use of uncemented stems in patients elder than 55 or 60 years, there is a higher periprosthetic fracture risk. But as the situation over here, there is still role of cement in cement revision. I want to just emphasize. I think that is a much easier way to deal with this case.
The trochanteric osteotomy and all, this is good, but like
No.
cement in cement compared to the uncemented long revision stem metal.
No, there are actually no studies mentioning that comparing long stems and cement in cement revision. We might just need to go on a case to case basis. On the whole, the whole picture is you are saving the bone. You are saving the bone for another revision. For another revision. Because if we use the long stem Wagner stem or anything, you are using the gold zone. As Dr. Vijay Bose will mention, there is always a gold zone in the mid thigh where you always need to conserve. So I think this might give him another 10 to 15, 10 years maybe. Then if this guy comes with for another revision, then we will go into that zone B.
We didn't have any, I mean, lucency in the bone cement interface. So
No.
that is very, if you go to the previous X-ray, so it is quite, see, there are no signs. The cement is very well integrated and close to the bone.
Yeah.
So whatever cavity and since you do a downsizing of the stem, see what we need, cement is basically grout, it is not an adhesive.
Yeah.
So if you can fill this space properly and have a integration without any defects or lacunae, I think this will survive.
This will survive.
Should
My
be-
idea is to give him another 10 to 15 years so that if he needs revision, he should need revision for loosening, not for implant breakage. Yeah.
So did you change the cup?
No, sir. I am a conservative surgeon again.
And you retain the same 32 size? Or
No. I retained the 28 head only, sir.
28, it was 28.
28 head.
Okay.
It was a 28 head. A new 28 head.
Actually, sometimes doing less is better than overdoing it.
Yeah. Yes, sir. So this is another case of failed PFN, operated multiple times. What is your choice? Do you want to go with bipolar or a total hip?
No.
For a failed
I
intertrochanteric.
prefer modular hip. Yeah.
Modular?
Modular total hip.
Modular total hip, not a bipolar.
Not a bipolar.
Okay. So all failed intertrochanterics, you go for total hip.
Defragment is there and the fracture also is unstable. And we have a broken implant. So better, what I feel is modular total hip.
Modular total. I want to emphasize that point only, that any case of intertrochanteric failed PFN or failed DHS, it is always better to go with a total hip replacement. Because your surgical time will be increased only 10 minutes to put your acetabular socket. But once he comes with a failed hemi replacement, you again need to face the music. So, as Dr. Rajshekar has mentioned, you can go ahead with a modular implant or a long stem or a cemented femoral stem, in this case hybrid. But normal uncemented, I think it will not suffice. As he has predicted, yeah, there is instability of the fracture over there, but still it is completely fibrosed. So I just went ahead with a hybrid total hip and she's absolutely fine walking. So this is another case where I am not the index surgeon. Inadvertent. No. Actually, I have also broken one of my cases in this fashion. So I don't need to stray away from these sort of complications. But I'm just mentioning that I am not the index surgeon over here. Inadvertently, the posterior column and the medial wall have been breached. So how to go ahead with this case? Rajshekar. Actually, to put a cage, the patient's age is only 35. So cage is out of question.
Cage you can have standby and you can try with a trabecular
Yeah.
and mesh also. Nowadays mesh is also available.
Okay.
You can have a trabecular cup with mesh, you can try. Otherwise, go with cage as a standby.
Stand by.
So trabecular cups sometimes even with complete loss of acetabulum, central acetabulum, it would be fitting. So I feel young patient you can try that. Once again, it case to case basis. After you open it and remount.
Yeah, actually, I didn't have the CT scan picture, but I have done a CT scan. Actually, here the posterior column was completely broken. It was fractured, and the medial wall was breached. Anterior column was totally intact in this case, but I couldn't retrieve the CT images. Sir, how would you proceed with this sort of case, sir? Anterior column is intact. Only the posterior column and the medial wall were breached.
And before that, this breaching of the medial wall, is it because of the reaming or because of at the time of impacting the car?
I think it was during impaction, sir. During impaction or reaming. I don't know because I was not the index surgeon over there.
Even in the other side,
Mm.
there seems to be a small element of protrusion there.
Yeah.
going on. So this side with the protrusion, some amount of reaming until you get bleeding and backing in your go inside. And see, the thing is, getting this, I won't talk about what happened because I know what you did, so it's not correct on my part. But this is a thing which is avoidable if you
Yeah.
keep the keep in mind the stabulum.
Mm.
30 at this age,
35. 35. 35 female.
element is there. So we should be cautious when doing.
Okay.
That's my. Anyway, we'll show them next.
I went ahead with only posterior column plating first. First, I had fixed the posterior column, so I now have a decent, stable acetabulum. Then I had put a trabecular metal shell over there. It's not a trabecular metal shell; it's that partly trabecular Zimmer continuum thing. I think continuum. So it will have much more better osteointegration than your normal uncemented traditional versions. So because why I restrained from cage is cages have only survival rates of only 5 to 10 years. Cages fail very fast.
But Link has a uncemmented cage.
Okay, sir. But I think we don't.
Longer
Uh,
survivor. The Berkshire case will fail in
5 to 10 years.
because it's cemented cage.
Yeah.
Uncemented cage lasts longer. Link has.
Okay. Okay, sir. Yeah. You told me that you have used in one or two cases.
That is always better.
Yeah.
As long as you said, posterior column reconstruction or by using a trabecular cup or any trabecular augment, if you can get away, that is always better.
Always better.
Using a cage.
Yeah.
What is weight bearing schedule for this?
I didn't make her walk for first 6 weeks, sir. I just made her sit, and after that, only partial weight bearing and female patient. Yeah, this is another case. I think she has been operated multiple times. I think 5 or 6 times. She has been operated for a intertrochanteric fracture. Subtrochanteric, intertrochanteric with subtrochanteric extension. Failed PFN, and they have used a long bipolar for a failed PFN, and then she landed up with infection, and cement spacer has been put, cement spacer has been removed. So I think 5 or 6 times she has been operated. So now the infection is clear. ESR, CRP have come to normal, and she wants a hip. What is the choice of implant?
Acetabulum is
Sir?
acetabulum. You can go with the trabecular acetabulum.
Hmm.
Maybe you can have a little higher center,
Okay.
higher center,
Hmm.
and then go with, as sir is suggesting, Wagner stem.
Okay.
Wagner stem. I feel so because almost up to subtrochanter there is no good bone quality.
Hmm.
Always better to have a long stem, revision stem. Better.
Yeah, Wagner is, I think, the first choice here. Sir, coming to bearing, do you want a traditional metal on polyethylene bearing or any chance of dislocation? Because I am not sure about the abductors over here. So, any dual mobility or a constrained?
Better because less chances of dislocation. So dual mobility in young patients is always suggested.
I differ from that. Dual mobility in young patients, there are no really long-term studies, but only in special circumstances we should be using dual mobility. This is, I think, the traditional teaching.
Whatever I'm doing, Duralock cups are coming, so Duralock always gives a peace of mind for surgeon. At least that way we can get away with it.
Yeah. Sir, do you have any difference of opinion in the liner option?
Go for a bigger head. 36 would be an option.
36, I think we will not be able to fit it here, sir, because she will be getting around 44 or 46 cup, not much more than that. So I think dual mobility, if it comes, if it fits in our budget, it should be fine. So I had done a traditional total hip with a Wagner type stem and reattached all the abductors. And I'm decently confident that intraoperatively that there were no chances of dislocation. And it has been only 3 months since I operated her, and she is fine doing. So I will update the long-term result. Oh no, short-term result also once in next sessions. But she has decent stability. I was much worried about the intraoperative stability, but she had decent stability. So thank you for giving me this opportunity. And not last but the least, I would like to thank our Arogsri scheme also, NTR Vaidya Seva scheme also, for providing us this opportunity and providing impetus to the patients also to get complex hips done, and providing us an opportunity to serve the patients. Thank you, sir.